Good evening. My name is Craig Durie. I had the fortune of growing up in a household with parents that spoke two languages. One of those languages being English, the other language being Afrikaans. I married a wonderful woman that speaks some French, and throughout my life I've taken some Spanish lessons from time to time. And I work as a translator. Now, the funny thing about standing up on a stage and presenting myself as a translator is the only language that I have any fluency in is actually English. And as you might see, at some points I periodically stumble with that. But I am being sincere when I say that I'm a translator, because what my lab coat at work says is nurse practitioner, palliative care. And what I speak is a little bit of the dialects in that world, dialects like cardiology, pulmonary critical care, oncology. And I also speak and listen to a core contingent of the layman's language, because the translation work that I and my team members are called upon to do is bring the information together in a manner that's understood by all parties involved in the health care of a patient. So imagine yourself for a moment in an ICU. You've got a wonderful, caring family. There's 5 devoted family members that are each taking shifts visiting you in the ICU throughout the course of the day. And throughout that same day, you've got your cardiologist that's visiting you. You've got your nephrologist who's checking in on your kidney function. You've got an oncologist that you've never met before that's also checking in on you. You've got a variety of different team members. They're all meeting different family members of yours during the course of that day. And they're talking about your health status from a little bit of their own perspective, from what they're responsible for. And the next day, a lot of your team members kind of switch out after being on call, and you've got kind of a different subset. You can imagine if at the end of that week, you're called upon to navigate some very complex and difficult decision-making about how you want elements of your healthcare managed, that might be a very complex and daunting task. What I'm often called upon to do is step into that environment, learn about the patient, and I might start by asking, tell me what you're hearing from the rest of your healthcare team, because then I can begin to comprehend what they know, what they've heard, how they've processed that, where those gaps are. But I'm also going to ask them, tell me what you used to do for a living. Tell me what you do for fun. What puts a smile on your face today? And some of the questions that are deceptively easy can also be deceptively difficult. Tell me what you're worried about the most. Help me figure out what the concerns are. Who is your support network? And as I gather this information, I can begin to look at what they're motivated to receive in terms of healthcare, what their priorities are. And I can begin to match that up with what we're offering. We call that clarifying the goals of care. That's one big role that palliative care is called upon to do. And in doing that, we reduce a lot of anxiety and distress within the family unit and for that patient themselves. Not to say these conversations are easy, but when people have an understanding of what some of their options might be and what they're up against, they can actually grapple with that. In doing that, in reducing that stress and anxiety, I'm also focusing on what are their physical symptoms and cognitive symptoms, emotional symptoms as well, and trying to medically manage some of that at the same time. So we're really engaging in work that helps protect a quality of life as best as we can, but by clarifying those goals of care, we're also bringing efficiency to the care we provide for that patient. We're avoiding unnecessary tests or things that might not make sense with what the patient's objectives are. And at the same time, by doing that, with that efficiency and that clarity, we find that people are spending a bit less time in the ICU, and there's also less readmissions to the hospital as a result of that. So we may clarify things like, do you have an advance directive? What should your code status be? What are your thoughts on being on a ventilator for a long period of time? Would you ever accept a tracheostomy to make that semi-permanent? Is artificial feeding through a tube something that would make sense? Are more readmissions to the hospital serving you well? Should we continue that? High-risk diagnostic testing. Do those have enough benefits to outweigh the risks from the patient's perspective and with a good understanding of their health concerns? I was called upon about 3 years ago to see a patient that really opened my eyes to an unmet need in doing this kind of work. It was a woman who had been life-flighted in from a hospital in the Pocono Mountains to our hospital. And the order for the consult read, clarify goals of care, patient refusing everything. And that usually means that we've either done a rather poor job of explaining what we're offering, or we've done a less than stellar job at listening to what the patient is asking for. I arrived at the bedside to find a woman in the ICU who was alert, not on life support, perfectly able to have a rational conversation with me. And in talking to her, she was flown in for valvular heart disease, an evaluation for valve replacement surgery. And I began to explore why she was refusing the cardiac cath, and a bit fed up with some of the consultants, the lab work, and the echocardiogram that was being ordered. And the one statement that summed it up beautifully was she looked at me and said, "Nobody said anything about cutting on me." $12,000 to $25,000 for a flight. And we'd kind of missed the most fundamental question before she left her hometown hospital of asking, what are your goals? What would you like us to accomplish with this transfer to this hospital? We did clarify her goals. She accepted that being hospitalized 1, 2, 3 times a year was acceptable enough as opposed to the option of surgery for her. Not everybody would make the same choice. It wasn't my job to tell her what the right choice was, but to help her articulate that. So she went back up to the Poconos, back to the support of her family. And it was about 3 days later that I was sitting in front of a telemedicine monitor that it occurred to me I could have had that same conversation with this woman, likely with her surrounded by her family, from 100 miles away, or quite literally from the opposite side of the planet. That set me to exploring a little bit further, because what I wanted to understand better is how big of a need is there for palliative care in these smaller hospitals that dot the Pocono Mountain Range, and are also really throughout our entire country, hospitals that aren't as big as the tertiary center where I practice. So I pulled data from 3 of those hospitals over a 1-year period. I looked at diagnoses that would be appropriate for a palliative care consultation, complex life-limiting disease. And what I found is in the course of 1 year at those 3 hospitals, there was 1,369 patients who would have been appropriate for a palliative care consultation. Palliative consultation also has an impact on rate of readmission, because sometimes if we clarify the goals or effectively manage things, people don't need to come back as often. What I found is there was about 3,600 readmissions in that 1-year time period. That's a difference when I compare that with hospitals that have a palliative care program. The difference being about 17% greater readmissions at those hospitals without access to a palliative care team. So this matters. It matters partly because we also have a national shortage in palliative care providers. So I started to wonder, are people doing telemedicine consults in this capacity to meet that need? And as I looked at the national data and publications, I found that doesn't really exist yet. So I started to explore a little bit further. I spent some time with one of my colleagues that does infectious disease consults remotely. And I observed him doing a consult with a patient with moderately advanced dementia. And he was really talking to the patient's son that was at the foot of the bedside. He was being treated for recurrent infections and cellulitis. And at one point he puts the family on mute, turns to me and says, "Is this a good place for a palliative care consult?" And I said, well, I would probably ask if there's anybody in the family who's power of attorney to navigate medical decisions. Have they talked about a living will at an earlier point? Have they had any thoughts about recurrent readmissions at the end stage of dementia, and when they might want to not engage in cyclical admissions for that recurrent phenomenon of infections that typically ends the life in dementia? Have they talked about artificial feeding? He said, okay, took the family off mute and rolled me in front of the camera. And I found very quickly that that conversation was just as natural from a few hundred miles away as it was if I was sitting face to face in front of a family member. It was eminently doable. I wish I could say that some of these consults were that simple. There are also consults that I see as emergency and high impact. I had a conversation with one of my ICU colleagues who really told me a story that hit me to the core. She was receiving a patient, 87 years old, who was going to be flown in from an outside hospital. And in receiving that report, she was hearing information of lab values that were frankly incompatible with life. For all intents and purposes, this is a woman who is actively dying with multi-system organ disease, and we would most likely be successful in prolonging a dying process for her, as opposed to reversing it or leading to a different outcome. So she asked if anybody had talked to the family about whether or not they wanted this transfer or how they would perhaps support end-of-life care there. And the response she got was, well, we don't have the time to manage that. We don't have the time to talk to the family about all of that. It's your job to take her. We're sending her. She got off the phone, and it was about 15 minutes later that she heard the nurse getting the nursing report on that same patient. And she happened to overhear the phrase, "We're not sure the patient has a pulse anymore." They were, in fact, preparing to send a patient that had died. She did ask that they go back and check to see if there was a pulse. So she didn't. They didn't send the patient. But the reality is that was probably a family in crisis, that we could have rapidly talked to them, clarified some of the goals, also explained what we could offer, and accepted the patient if that's what they wanted. Or perhaps provided end-of-life care in that patient's own home community, surrounded by a family network. We risked doing that from a few hundred miles away with likely the same outcome. So, in this work that I do a lot of difficult consults, and that drains my emotional tank at the same time. But I do this work because it helps improve quality of life, it helps shorten the length of stay, it helps reduce cost, and is deeply emotionally meaningful. Some of the family stories that refill that emotional tank for me are as follows. I've met sailors from World War II that were among the first to cruise under the polar ice caps in submarines, that crashed airplanes and survived. I met a Major League Hall of Fame baseball player recently. She was an amazing woman. She worked for 30 years as a welder after that. I met a skydiver that had done over 1,000 jumps, some of those during the daytime, some of them at night, some of them with clothing, some of them without. I also recently met a woman with purple hair and end-stage COPD, and she was astute enough to be fearful that her family would allow her life to end on a ventilator in an ICU or in a nursing home with a tracheostomy. She was clear those were things that she did not want for herself, but she had trouble conveying that to her family. They were all arguing for aggressive things, and they were doing so out of love for her. So we called a family meeting. We brought that family together. I sat next to this woman, her family sat on the bed, and I talked through the advancing nature of COPD and what those aggressive interventions would offer and what they wouldn't offer. And then I explained that she didn't want that and that we weren't going to do that. That family was able to hear that message in the context of her disease process, parallel with her wishes and her goals, and were able to come together and support that. I thought the meeting was over. I thought we'd clarified the goals, and then she said, "And when I die, I want to be cremated." And then the argument over funeral arrangements broke out. I couldn't quite get out the door. They were blocking my pathway with some of their seating arrangement. So they just continued to argue and bicker. It's not normally my purview to figure out the after-death concerns. And with pregnant pauses in her COPD and deep breaths, she says, "And when I die, and when I'm cremated, they can take my ashes, they can put them in an Etch-a-Sketch, and they can play with my knobs all day long." And when that family broke out into laughter, they also understood those wishes were valid. That family was together with her and able to understand her wishes and honor them. This is the work that palliative care does. We can bridge the gap across geographic boundaries to do this through the use of telemedicine, and we should. Thank you.